Welcome to This Week in Health IT. It's Newsday. My name is Bill Russell, former healthcare CIO for a 16-hospital system and creator of This Week in Health IT, a channel dedicated to keeping health IT staff current and engaged. Special thanks to Sirius Healthcare, Health Lyrics, and Worldwide Technology, who are our Newsday show sponsors, for investing in our mission to develop the next generation of health IT leaders. We set a goal for our show, and one of those goals for this year is to grow our YouTube followers. We have about 600 plus followers today on our YouTube channel. Why, you might ask? Because not only do we produce this show in video format, but we also produce 4 short video clips from each show that we do. If you subscribe, you'll be notified when they go live. We produce those clips just for you, the busy health IT professional. So go ahead and check that out. Now on to today's show. A view from Capitol Hill with Mari Savickis with CHIME. One more quick note before Mari chimes in, and that is we're going to go on a summer schedule starting in June. June 1st, we will have a Newsday episode every Monday, and we're going to have a influence episode every Friday. Those are the conversations we have with industry influencers. We may drop a solution showcase in there from time to time on Wednesday, but that's going to be the exception. And if you still need more, we have our daily show, Today in Health IT, which is around 8 minutes long. We look at one news story every weekday morning. Those will continue. This is just a chance for you to catch up on some of the shows you missed, or just take a break and get outside, whatever works for you. All right, today, Mari is in the house to talk about all things from our nation's capital. Mari, welcome back to the show.
Thanks, Bill, for having me. Always trying to keep it interesting over here.
Well, you're in the capital. Of course, things are interesting. Now, we're not going to necessarily talk about the really interesting stuff, but we're going to talk about healthcare, and there's an awful lot going on with regard to healthcare in the capital these days, I would assume.
Yes.
I
wouldn't know exactly, Bill, because like the Capitol's still pretty much shut down, but you can kind of get in if you give away your firstborn.
That's like everybody.
So we'll talk about theoretically.
The Capitol is shut down. That's like happiness to everyone's ears. We're just sort of, the government is shut down. I don't have to file my taxes or anything. Actually, tax day's coming up, isn't it?
No. We're on just a big delay.
All right.
Taxes are delayed. Everything's delayed.
I know. Well, hey, Mari, I don't often do this, but today you get to pick the topics. We're going to discuss what you want to discuss. What's top of mind right now in our nation's capital?
Well, everything's, all of our hot topics are always front and center. We've got telehealth, that's been in the news very recently. We've got information blocking and interoperability. We've got that 365 days a year over here. And, we've got things like cybersecurity. That's another hot one. So I don't know, I just give you a grab bag of 3 things. So which one should we start with? Well,
and we're going to, the good news is we can probably go a little deeper than we usually do on any of these. So let's start with cyber. And, I covered the most recent breaches on Today in Health IT, I think just yesterday. And I posted this out on LinkedIn. And as I'm trying to get the conversation started on LinkedIn. People can follow me at Bill J. Russell on LinkedIn. And this is what I posted. I said, cyber carriers are parked off the coast and they are attacking healthcare. It might be a provocative statement if it weren't true. Consider this. What would we do if a foreign or domestic group or even a person were to walk into a hospital or a group of hospitals, go down the hall to the HIM department, set fire to all the records, completely destroying them. And once they were done, they would just saunter on over to the data center, kick on the sprinkler system, turn the computers into nothing more than paperweights, and then they walk away and start doing it to the next health system. And I go on to say, well, that's what's happening, and it's happening with more frequency and bigger targets. This week, we already know that at least 4 health systems lost all their records. I mean, the ransomware came in, essentially annihilated them. All their records, all their images gone. Now, we don't know exactly what's happening, but Scripps this week, it's in the news. It's in the San Diego Tribune Union. I forget what the name of their paper is down there, that essentially they're on paper processes, that their portal doesn't work, that they're doing diversion and those kinds of things. We don't know exactly what it is, but looking at it from the outside, it looks like ransomware at this point. What are you hearing on the Hill? I mean, is that overstating it? It just feels like there's an awful lot of attacks and activity coming at healthcare right now in the cyber world.
That's really scary, right? So
Yeah.
I've been reading about some of those things. You've clearly devoured the cyber news, so I applaud you for staying on top of that. I just read a statistic that said that this is for one big health system in Boston, that they're attacked every 7 seconds, which is just like, how do you handle that level of stress? So let me turn off my printer and tell you what I am hearing over here. There's funding for CISA, right? There's a lot of funding that's being dumped into CISA, though none of it right now is especially targeted to the healthcare system. I'm sorry, I have background noise, Bill.
No problem.
So I think it was like $650 million is in Biden's plan, and that's a lot of money, right? But we need to figure out how this is going to actually, I guess that's already actually been appropriated, how that's actually going to be spent in terms of each sector, right? Healthcare. And we're so interconnected. If you think about some of the storms in Texas, right? Storms in Texas, electric grid, healthcare, you kind of don't want to be at the hospital that loses power or gets, like I guess assaulted, like you just described. And so these really are big challenges. I mean, I do think that this is on lawmakers' minds. I know that also President Biden is coming out with a cyber executive order very shortly, expected later this month. So there's attention being given to it. I think from the healthcare perspective, it's just like, how much attention can our sector grab? You might say, oh, that's kind of surprising in the middle of a pandemic, right? But there are other sectors who are also getting attacked, and I know that the president's focusing on a cyber sprint around electricity, and that's laudable. We hopefully would see something similar in healthcare, but I mean, it is getting attention. It's just like we're trying to get them to focus in on healthcare is something that we're working on doing.
Yeah, it's interesting. I used the imagery of cyber carriers parked off the coast and in the Gulf of Mexico. I used that imagery on purpose because if there were carriers off our coast, it would be the federal government's responsibility to do something about that. We wouldn't expect the state of California to get their militia and start sending boats out to look at nation states and others that were coming in. We'd expect the federal government to do that. And I use that imagery to say, I think we're at that level now. I think we're at that level where the attacks are so sophisticated and they're so violent. I mean, they're destroying records. They're really going after healthcare in a strong way. I think it's more than just, this, again, to a certain extent, I get to say my opinion, but you have to work in that space. So I understand you maybe not being as strong with your opinions as I would be in this case. But it feels to me like the federal government needs to step up almost with like a military action to protect our health systems and to have that level of preparedness and funding and sophistication in order to protect our health systems. Because it's one thing to look at a large health system with 50 hospitals and a $200 million IT budget and say, yeah, they could probably figure out a way to protect themselves. But it's a completely different thing to look at a federally qualified health clinic or some of the smaller health systems and say, hey, why can't you come up with enough budget to protect yourself against this crime syndicate that's trying to get in? Well, they just don't have that kind of money.
I mean, there's nothing you've said that I don't disagree with. I mean, if you want me to get all spun up, I mean, people who know me pretty well, though, I can get pretty passionate. So, I mean, it doesn't take that much for me to get all riled up. I don't disagree with anything you said. In fact, I love your analogy or your imagery about like the pirates offshore, and that, usually it would be like the US Navy or something would go after them. I mean, so we need some sort of like cyber, rescue plan. I may have to like gnaw on that one. I like where you're going with that. So, I think some of the challenges we face are a fewfold. We're in the middle of a pandemic. We have bailouts and rescues and stimulus packages for not just healthcare but multiple sectors. We have now the infrastructure package that is being considered, right? And like the Republicans and Democrats are in very different spaces in terms of like what the price tag will be. I know like the LIFT Act has something that's been driven by the Energy and Commerce Democrats that that has some cyber pieces into it, and that's really helpful. But what the ultimate plan will look like for the infrastructure it's hard to say. I mean, I think right now the talk in Washington is like, oh, we're going to do this in a bipartisan manner, but ultimately, because the price tag that the Republicans want versus what the Democrats want is so vastly apart, like they're not even in the same ballpark, that this will probably be done through reconciliation. So like a straw mark tactic. It's hard to say if cyber will make it in for healthcare and to the end of that. I mean, we certainly hope so, and we'll keep advocating for that. We've been pushing pretty hard. And I'll turn to some, again, like reminding people about some of like the positive things that we've gotten lately, just to kind of bring back and try to look, I'm a glass half full kind of person. These aren't, not to say that what you've said is we need more help. Absolutely we do, like absolutely. And so to pivot just for a moment on the positive, I would say that, first thing, Bill, is like, first thing is acknowledging we have a problem, right? So sometimes we have to start there when we're talking with policy.
Right.
Several years ago, no, I'm being serious. Several years ago, you would have a situation where certain major policymakers would not even acknowledge that cybersecurity incidents against healthcare systems and clinicians and hospitals and so forth were a patient safety incident. Now that is standard, like the standard accepted, parlance. But we weren't even there a few years ago. So, okay, so finally we admit that we have a problem. Yay. Now we need some more funding for it, right? So we did, on the last podcast I did with you, we talked about HR 7898, which is going to bring forward some, instead of like the penalty approach, it'll be more carrots than sticks, offering some relief by adopting voluntary best practices. Now, we haven't seen the rule yet. That just happened. It was just passed in law in January. So like something to look forward to, everyone. So that's one good thing, right? Cyber donation policy, start getting a kickback. That's, still like there's some hesitancy around that, though. You can do some donations of hardware. That's good. So these big ticket items, and I was just looking up, I'm sorry, I don't have every single figure committed to memory, but the president's skinny budget calls for 2.1 billion for CISA. Again, not targeted towards healthcare, which is what you're getting at here, but we're going to keep chipping away at that.
President's skinny budget? We have a skinny and a fat budget, or help me with the lingo here. I'm learning here.
See, we're in the Beltway here. So for your loyal listeners, what happens is usually they call it, we have all these weird terms here in DC, like skinny budget. It's not really a skinny budget. It just basically means like the high level numbers that are presented. It's not the granular details that fall underneath. And so I can send it to you afterwards, but the high level numbers show you what is being presented. And then a more robust, detailed budget is put forth. It's later this year, I think, because of the way that this year got started. But when the fuller budget or the more detailed budget is released, we'll have a little bit more idea about what's like how each pot of money is intended to be spent.
It's interesting. I think they're just, when I tend to go back to my CIO role. We all go back to what we know. And I go back to that role, and I hear what you're saying. Banks get attacked just as much as hospitals, as do retail organizations and whatnot. We saw Target a couple of years ago, and I'm sure Walmart's getting attacked on a daily basis. And any senator, congressman, or whatever that didn't think this was real, I could have showed them our logs from 2011 when I came in as a CIO to healthcare, and that attack every 7 or 8 seconds was absolutely true back then. Now we were a little more ahead of the curve back then. They were not getting in as often as they are now, but they are getting very sophisticated. These ransomware attacks, these malware attacks are getting much more sophisticated. They're finding our backups and destroying our backups. They're also not as overt. When they get in, they don't like celebrate like, hey, we got in and we're stealing records. They look for the most opportune way to, and I think most of it's about money, most opportune way to make money. And I don't think a lot of these attacks we're reading about right now are nation states. I think they are organized syndicates and crime that is trying to extort money out of healthcare. But healthcare seems to be susceptible. I think what I'm asking for, when I think about it as a CIO, my budget went from 2 million the first year to 6 million by the time I left for cybersecurity on an annual basis. And that wasn't enough. And part of the reason it wasn't enough, and again, 16 hospital system, we're protecting 3 million patient records. The reason it wasn't enough is because, we're trying to defend against people that their budgets are far greater than ours. And they're hiring teams of people, and they only have to get in once to start making their way through our health system. This is where I think I would want here's what I want to say to congressmen, senators is look, I think it's a military response. And I'm not saying a military aggressive attack. I'm saying it's a military defensive posture where they are working with us to create a defense around our health system, just like they're talking about creating a defense around the electrical grid and our water supply and those kinds of things. If our hospital systems go down, yes, we can go back to paper, and a lot of us do throughout the year. We have systems go down and whatnot, but at the end of the day, to lose all the images for a health system or to lose all the medical records is a pretty serious blow to our nation, to our trust in healthcare and our health system. So I'd almost like to see a coordinated response. And I keep coming back to the military just because they tend to not put, $10 million in this budget, $8 million in infrastructure, $2 billion over here, $5 billion over here. I'd like to give it to somebody who's sort of looking at it as creating a defensive plan to protect the assets of the country. But again, I'd have to think about this one more. But I appreciate what you're saying. Glass is half full. A little relaxation on the Stark laws. We can now help some of the physician offices, and that is helpful. And we're starting to see some carrots instead of sticks. So cyber is interesting. But do you want to go to telehealth next, or do you want to go?
Well, before we move on, I don't want to leave any of your listeners with the impression that we don't think this is as bad as you say it is, because it absolutely is. I mean, I would challenge the listeners of if you have ideas about how to crack the code on this. I mean, we'll give you my email at the end of this, and I'd love to hear what your listeners have to say about what we should be asking for, because we don't have enough time to spend talking about all the different things that we do ask for. But the door's always open over here. And, I'd love to hear, I like this interesting idea of the military response. I'm going to nod on that one, but have your listeners send ideas over our way so we can try and, crack the code on this.
Yeah, but that's what you guys do. You're on the Hill representing us.
I live and die by stories, right? Your hearts and minds, I always say this about hearts and minds in Washington are one story at a time. So right now there's a story, right? You talked about 4 health systems being under attack. I read about the Scripps one, they're on diversion. That means that literally, unless you're having, trauma, you're getting sent to another hospital, which is really not great, right? So that's a patient safety issue. So send your ideas to me, please.
Yeah, diversion's bad. As a CIO, when technology has led to diversion, that's
stressful.
Yes, to say the least. All right, let's talk telehealth a little bit. We're getting so many conflicting things about telehealth. It's really interesting. Healthcare finance news, most consumers want to keep their telehealth after COVID. I think that's the most common thing we're hearing. I saw another study where people said, hey, I want to get back in front of my physician. So you have conflicting sort of stories there. The healthcare finance news said almost 88% of Americans want to continue using telehealth for non-urgent consultations after COVID-19 has passed. And I think that's true. New York Times had an op-ed by Elizabeth Rosenthal, who is a doctor, a former emergency room physician. And, she talks about the challenges of telehealth. And I'm going to read a little bit of this because I thought it was interesting. But again, it's an op-ed. This isn't researched piece that, we need to give as much weight as some other things, but it was interesting. She goes on to say by April 2020, one national study found telemedicine visits already accounted for 13% of all medical claims compared to 0.15% a year earlier. And that was really true. They looked at those claims. COVID-19 let virtual medicine out of the bottle. Now it's time to tame it. And this is one of the reason I pull this up because it's one of the few articles I heard about like this. And so I want to discuss it with you. If we don't, there's a danger that it will stealthily become the mainstay of our medical care. Deploying it too widely or too quickly risks poorer care, inequities, and even more outrageous charges in systems already infamous for big bills. Right now, there's a lot of focus on shiny objects, ideas that sound cool rather than solving problems, said Dr. Peter Provost, a national expert in medical innovation at University Hospitals in Cleveland, who has written about finding the value in virtual medicine. We know we know preciously little about its impact on quality. With telemedicine generously reimbursed, many practices are offering, even encouraging patients to visit virtually, but intentionally or not, that choice becomes a revenue multiplier, adding to the patient expense. And then they give this example, which I hadn't really considered. When he noticed a curious rash, a relative was first directed to a practice's telemedicine portal and billed $235 for a 5-minute video appointment. Since rashes are often hard to evaluate in 2 dimensions, he was told he needed to see a doctor in person for a diagnosis and then charged $460 more for that visit. I worry that the pandemic era reimbursement practices have taken traditionally free screening calls and rebranded them as billed visits with no value added. Again, op-ed piece, and I don't want to give it the same legitimacy, but one of the things I find when we're talking to technologists is we just say, telehealth visits, they're efficient, they're, practical, they're increases access, it's, a convenience factor. We just assume that everybody wants it, and we have data to support that everybody wants it. Is that the current sort of mantra? Everybody wants this. This is good. It's been good. Quality is backed up by it, and we should be running after this? Or is there any hesitancy around this?
Like so much to unpack here. At the top of the call, before we all went live, you said I could ask you questions. So we're both patients. Let me ask you, what's your opinion of what you just articulated? And then Dr. Provenos is a well-known patient safety and quality expert. So, his thoughts, carry some merit, but I think I'm interested in hear what you have to say first, so that I can dive into my diatribe.
Yeah. So a couple things. One is we have to define telehealth before we have the conversation, because when we say it, it is so broad, but it's really 3 things. It is video visits, video consults, and remote patient monitoring. And each one has its use cases and each one has its application. Every time we talk about it now, people assume it's just video visits, and we're seeing a growth in remote patient monitoring. And you know what? Video consults between doctors and those kind of things is highly efficient and should continue to grow at whatever pace it could possibly grow at, as fast as it can. Remote patient monitoring will be interesting to see how it grows, because we need more use cases, but it gives you more touch points around between the patient and the doctor, especially chronic conditions, type 2 diabetes, type 1 diabetes, Livongo and other things to that effect are good ways to get more touch points. But the video visit is interesting to me in that, if I'm getting a $235 bill for a 5-minute video appointment where they didn't diagnose anything, yeah, I'm going to have a problem with that. And by the way, I'd have a problem with anyone who did that to me. That, hey, we couldn't really diagnose anything. That 5 minutes is going to cost you $235. If a plumber did that to me, if anyone did that to me, I would be upset. And so that kind of pricing model needs to be looked at. We need to dig into the claims data that we got for the better part of a year and say, okay, what are we finding? How are people using this? How are they billing it? What codes are they using? And we should have a ton of CMS data. We should have a ton of commercial data to see where this is working, where it's not working, and then tweak the dials around this. But me personally, I love video visits. I think it's convenient. It saved me an ER visit during COVID, which was great. So I like that aspect of it. And it creates more of a relationship between me and the health system, which I think long-term is good. I think there's a lot of benefits to be had. Now, my mom will have none of it. She's ready to go back and see her doctor. She had AFib, and the doctor caught it in a routine visit. And her thinking now is that would not have been caught if I wasn't sitting in front of that doctor, and I probably would be dead today if I had not been in front of the doctor. So she wants to have nothing to do with video visits. And so that's sort of where I come down on.
Once you've seen one patient, you've seen one patient. So there's probably like a lot of different views on, what the future of telehealth should be for citizens. I mean, like I personally am the mother of a special needs child. And I typically travel 2 hours to, world renowned, definitely well known in the United States facility to get his care, navigating 2 beltways, and then him, who is hard to manage. And now during the pandemic, I have the luxury, is that the right word? The luxury of speaking to this clinician minus having to mask up and drive 2 hours and all. So it's been actually incredibly helpful, but I'm only like one patient, one use case. So I think that I agree with your sentiment that it has to continue to be studied. And that's something that CHIME has supported. We actually do think it should be monitored. I don't think that COVID is like the perfect use case. We were thrown into a pandemic, and yes, there's a lot of data, but it wouldn't be like an apples to apples comparison, right? There's still people who had to hold off on getting care that maybe the health system felt wasn't like needed and like urgently, but they still wanted to get done. There's still probably there were cases where you had to hold off care that really should have been taken care of, right? Because of COVID. So it's not the perfect example of apples to apples comparison, this data that we have now for about a year, right? So I agree that it needs to be studied. The other thing that is in question, and you brought up some equity issues, and I don't know that I have a good answer for that. That's part of the study thing, is audio. That's one of the issues that's being discussed in Washington, D.C. There's a ton of support for moving, at least among provider associations and other stakeholders, moving some of these telehealth flexibilities over the finish line, conclusively done. But, whether that's going to happen is really an outstanding question. If you gave me some money and said, like, go to Vegas today and start throwing down, where would my bet come down? My bet would come down that, and again, being really optimistic, I think what you're going to see is a situation where Congress kicks the can down the road, where it's like a middle scenario. It's not, no, you can't have it, but they're going to say, well, we're just going to extend the pandemic authorities a little bit longer, right? It's a kick the can down the road approach. Are you going to see the Connect Act over the finish line? I mean, I think if you talk to the most optimistic people in DC, they say, oh, sure, it's going to happen. But, that has to be balanced against the backdrop of all the other spending. And we don't know what the score is. So, I mean, we support the Connect Act, and, there's a lot of good changes that can happen. It's not going to deliver everything. You don't want to be perfect to be the enemy of good. But there are these outstanding questions that you've raised that have not been completely ironed out. Fraud and abuse, like our program integrity issues. Some lawmakers have real big concerns with that. There's a lot of merits. I mean, I don't think that we would disagree at all that this stuff has to continue to be studied, and there has to be quality improvement, and some of the other issues that you mentioned have to be examined.
Here's the thing I'm saying to my clients and health systems. There is a business model to make money out there, and Amazon's approaching it and running after it very quickly. It makes more sense on the payer side. If you're getting that first dollar for the care to keep people healthy, there's a business model. I think they need to be exploring. I think health systems need to be exploring that and stop sitting back and waiting so much on how is the federal government going to reimburse this? How is Medicaid? How are the states going to reimburse this? The equity conversation is interesting to me. I don't think people recognize. I read a study. I wish I had it in front of me. I think the number was in the 60s, 60 some odd % of the telehealth that was done, the video or the visits that were done was telephonically. It was not video visits. It was by telephone through COVID. And that would make sense to me. We still have a digital divide that exists. And I used to think it was just rural and urban, but it turns out within urban areas, that digital divide was really revealed during COVID, that there was, when you tell people, hey, stay in your homes and you don't get to go to the public library or wherever they normally go to get broadband, they have no way to get broadband. And so even within the cities, there's, I don't know what we call them, but let's just call it broadband deserts for people where they do not have access. And so their only option is telephonic care. And, at this point, we could probably argue, is it that much better for a video visit versus a telephonic visit? Quite frankly, if I'm talking to my doctor and they ask the right questions and I tell them some things, a lot of times they can say, yeah, it's an earache, I'm going to prescribe fill in the blank. But there are times where that video visit, they look at you and say, no, there's something else going on here. You should go to the ED. So clearly video would be better, but still a 60 some odd % is still telephonic. crazy.
Yeah. Okay. So yeah, there's so many things like we could get into. So like on the phone thing for a moment here, I think it just depends on the situation. Like I've also read like conflicting articles. I don't consider myself to have equity, issues for myself, but I don't have good broadband where I am. I'm 40 miles outside of Washington, D.C., and I have 3 forms of internet here, and none of them are high speed. So I'm speaking to you on a satellite internet, which is unstable. And then I have 2 hotspots as a backup, and it's spotty. I mean, there's also, I think one of the things we might see in infrastructure is some broadband funding, which will be really helpful to the healthcare sector. So that's good. Back to the audio for a moment. So I was just looking, we have this great resource I can send it to you. It's a little dated, but I can send it over. So Medicare, right? What does Medicare do? They move forward recently with like these, what they call technology services. They're not housed under the typical, again, here we go with like Washington, D.C., like splitting hairs, but they're not under like that bucket of the majority of telehealth services that Medicare is prohibited from really doing unless Congress changes things. They said, oh, okay, we'll let you do phone calls. Doctor can look at a video or an image and decide if you need to come into the office. So I could send this to you. That might be helpful for your listeners to take a look at that. There's like these little toes in the water, but these absolutely have to be studied. Like I don't purport to be some sort of expert on like equity. And I think it really depends on like what situation you're talking about. Some people may, again, based upon the articles I read, some people may prefer the phone because they don't like, it's phone or nothing, right? Phone or not going to the doctor, like that becomes an access issue. But then you also don't want it to be a crutch where they get like poorer care over the phone, right? So you could go like down many rabbit holes there with that.
I'll tell you one of the models
and RPM is also something that has to be strongly considered. You mentioned remote patient monitoring. That's like with all the burgeoning technology. And then like one last thing, I'm trying to keep all your strains of thought here. Let's go back to what you said about some of the technology giants and companies. So I know I'm throwing the question back to you. Are you suggesting that providers, traditional healthcare providers, replicate a model akin to the one that you referenced, where they just maybe charge like a flat dollar amount and skip insurance? Is that where you were going?
That's absolutely where I'm going. It's kind of funny. I mean, one of the most egregious money that was spent was all this money we sent to these large health systems, which have endowments of billions of dollars. It was the dumbest money that was spent during COVID. Now, I understand why it was needed for federally qualified health clinics, for rural healthcare, for some of the smaller health systems to shore up their balance sheets, but some of the larger ones did not need that money. And those organizations have plenty of money to invest in a different form of delivering care. The problem is it cannibalizes some of their existing revenue. But the question is this the future of healthcare, or is this just a fad or a passing thing? Well, we're going to find out, and it's probably not going to be healthcare. It's not going to be a healthcare provider that comes forward with it. It's going to be a Teladoc, and it's going to be an Amazon, and it's going to be somebody else who comes forward with it, and then healthcare providers are going to have to play catch up, I think, is what's going to happen.
I mean, you may be right about that. That's somewhat scary. I will say though, like many of the members of CHIME are not, those are some of the bigger ones at the top, right? And then you have maybe the federally qualified on the other end of the spectrum, but you have like many community-based hospitals in the middle, right? What I would call like the bread and butter of membership, who, without the right reimbursement are not going to be able to continue offering the same level of service that they were before. And so that always is, those are things that keep me up at night, not the ones who are so big that they don't even have to like charge for telehealth. It's more the ones in the middle, right? Where your community hospitals are disappearing, they're being bought up. I mean, how do they make that accessible? I'm near a community hospital here. I don't go to that hospital. Hopefully I don't go to the hospital ever, but whatever, if I have to. There's one not too far from us, and I don't know what their telehealth situation is. I haven't had to use it, but they are the bread and butter of the backbone of America. So we have to think about the folks in the middle. But I agree. Yeah. I mean, it makes me a little sad what you're saying. Again, don't disagree with it.
Here's what doesn't make me sad. I'm looking at Firefly Health, which is Jonathan Bush, his new thing that he's doing. And they essentially have this model for care that they've set up. And now they're launching an insurance product to go along with it. And they published their findings from the first year. And their average patient talked to a clinician 65 times last year. And his comment was, that's a good thing. I mean, they're calling about nutrition. They're calling about everything. And it's encouraged because They want to develop a stronger relationship between the clinician and the patient. And I'm looking at that model going, yeah, that's right. I have questions all the time that I go to the internet. I would never think of, talking to anybody within a healthcare provider, because first of all, it would be too hard to figure out who to call and how to get in touch with them. And second of all, they would look at me like, hey, I have no way to bill you for this. And to which I'd sort of get stuck. I like these new models because they're thinking about keeping me healthy, and they're thinking about keeping me out of the hospital. We still have a sick care model. Remote patient monitoring. The thing I like about remote patient monitoring is it keeps people out of the hospital. It keeps readmissions from happening. But at the end of the day, that means hospitals make less money.
I mean, I know who Firefly Health is. I'm not sure. I'm not familiar with their business model, but I would say that with some of these companies, like if it's a concierge model, you have to be careful, right? Because only certain people can pay into a concierge where you get to talk to someone 65 times in 1 year. So I'm familiar with those. And I was thinking back to the example you gave at the top of the call about a skin issue being improperly or not diagnosed on the telehealth. But I was thinking too, personally, from me being as a patient, having been misdiagnosed on what ended up being shingles. Yeah, got shingles, the gift that keeps on giving. And that was sent home like, oh, no, that's not shingles. And I'm like, and then 2 days later back. So I end up having to pay for being at the urgent care clinic like twice. So I think that goes back to quality, right? That goes back to quality. We're still in a fee-for-service system that pays for the unit of care largely, not the overall value of the experience. These are issues that are systemic to our overall healthcare system. And so I'll have to go look up Firefly's business model, because now you have me interested.
Yeah, I think that's interesting. I do want to touch on interoperability with you. And by the way, for people, I mean, this is why we do the show, is just sort of have these conversations. And you might disagree with me, you might disagree with Mari, and just shoot us emails. We're more than happy to talk about it. We're mining ideas. We want ideas. We want to have conversations around these things so that we can, I think the word is better. We want to be better every day, getting a little better at what we're doing. Interoperability. So, gosh, a lot happening in interoperability. Fill us in on some of the things that are happening from an interoperability standpoint. Obviously, we had the information blocking rules go into effect. Was it 2 weeks ago, 3 weeks ago? I forget the date exactly, but there's a lot going on in interoperability.
I have no idea what you're talking about.
Oh.
I'm joking.
There's an information blocking rule? You're kidding.
I could just talk about this all day long. It just makes me a power nerd. Yeah. Okay. So April 5th deadline came and went. The world did not cease to exist, still turning on its axis. I'm practicing yoga, Bill. So I say to myself every day when things get sticky, it's like deep breath in, long breath out. I say namaste, it's going to be okay. So yeah, there's, the day came and went and everything's fine. And we still get a lot of questions and there's still a ton of anxiety. I have a great team behind me. Andrew Tomlinson is the one who's spearheading our advocacy. And he's just just doing this entire regulation after regulation. We have infoblockingcenter.org that we keep pushing a lot of information out to, but I'll say we got a lot more questions than we have answers sometimes. And and the questions are getting more granular. He just did a webinar this week, actually, with the American Psychiatric Association, and it was on mental health and information blocking. How do you parse through some of there's a lot of complexity here, right? So yes, we have it came and went. There are still all listeners, there's no penalties yet for providers. So keep your shirt on. It's going to be okay right now, but still keep moving forward, right? Swim in the same direction, try to, document. So you have to, information blocking is a thing, even though we don't yet know what HHS is going to do. I'll take a deep breath here. I could go on and on, just pull the string, Bill.
So let's talk about this very pragmatically. And by the way, I don't expect you to know everything about everything, especially with regard to interoperability. I'm reading documents all the time, and there's just a lot to sort of take in here. But what I want to try to do is frame this up in a way that makes sense for people to talk about. So you and I, Mari, you and I are going into business. You left CHIME, I left what I'm doing. We're going into business. You and I are going to develop an app. And we developed an app so that patients can download their medical record from their local hospital. And you and I are smart enough. We hired some good people. We have a HIPAA high-tech compliant data center. We have TLS2. We're doing all the things we need to do to secure it. It is a secure framework, and we created an iPhone and an Android app for patients to do that. It only has 2 buttons. One is request the information from the health system, and they put in the health system information, or it says, log into your portal and we'll get the information through there. All right, so that's one button. The second button is report to the ONC non-compliance. I have 2 buttons on this app. And this obviously for simplicity in our business is not going to do that well. But those are the two buttons. We have a completely HIPAA high-tech certified, built by professionals kind of environment. So we put that in the hands of patients today. How many patients are going to be able to get their medical record from their local hospital, do you think? Today.
I think there's still challenges. I mean, here's the thing that remains to be seen is like how many people are going to use this. So I'm really curious to see as this continues to take shape. An email from a member, in fact, she was in the media. I'll send you her article. That was talking about she's been asking for help from her vendor to facilitate some of these pieces that are needed, and it hasn't been successful. But I mean, I'm not trying to use that as a scapegoat. So I think systems are swimming in the right direction, but not everybody can do it. There are exceptions in the information blocking, but I think that most patients are not looking for their entire kit and caboodle of their record. They're looking for one thing in particular. Like I had to get a x-ray the other day. Maybe I just want the x-ray. It's not likely. X-rays are still complicated. So that one is one where it falls, more in the grayish area. I mean, I might be able to get the readout of the x-ray, but not the actual x-ray. I could get it. It's just not going to be over, your app, right? So then I guess the patient says, I have been blocked, right? So then that starts the investigation, and I don't know. You're scaring me with information blocking cover.
Mari, I didn't get to the second button yet, which is I report
I'm
that.
Scared about the second button.
So the second button, I report them to ONC. There's no penalties at this point. I mean, is there really going to be an investigation? And am I going to be able to get the data?
That's not how. No. Everybody listening, listen, don't take Bill's advice there. Act like it's still a thing just because there's no penalty in place. I mean, here's what I've been saying to our folks, is that you got to start, not every CIO has HIM under them. Did you, okay, Bill, back to you. Let's ask you a question. Did you have HIM under you when you were a CIO?
No, and I know it from my clients, it's about 20%.
Okay, so there's so much that goes into this role that involves HIM. It's so much about it is involving education and down to the frontline staff who you're interfacing with, like, oh, can I just get a copy of that? Or, and someone who is at the, intake desk or the front office staff, it's going to be a lot of education. So I don't always think that, and this is back to me being like the glass is half full, but sometimes I just think it's like people just don't know what the rules are. Have you ever stood in line at a provider's office and been like, that is not correct. That is not that's not according to HIPAA. And then you have to educate them on no. So is that nefarious? Either way, the patient should get their information. I also want to say that our position is that the patient has a right to their medical records. CHIME supports that. I support that as a patient. I imagine that you want your access to your medical records, Bill, if you need something. So I don't know. I think there are varying states of readiness, and we just got to keep making sure that everybody is as ready as possible. It's going to be more of like an evolution than a revolution. I mean, it's going to take some time to get everyone where they need to be, right? I mean, we still have a long journey ahead of us with the FHIR APIs and all the stuff you mentioned, and I'll be looking for your app on my phone when we get off.
I went back and forth with a high-ranking vendor, somebody who I really respect and whatnot, and I said, look, this app could be developed very quickly. I mean, at the end of the day, it's not that hard. The information blocking rules say you have to provide to me the US CDI data set via FHIR, and writing that app for somebody who knows healthcare data and whatnot, again, not that hard. And I sort of made, half jokingly, I said, this could be written in a week. By the way, it probably could be written in a week. It's not that sophisticated to make that call, and especially to make it through a portal is not that sophisticated to do. It can be written in a week. It needs to be tested and all those other things, and it would need to be certified and whatnot. So it would take more than a week to actually do it. But at the end of the day, writing that app to get the USCDI data, and I'm not talking about I need my images, I need all this stuff. I just want the core data set that is being supplied today. Now, in a year, that data set goes to unstructured data, and that's a different case. And by the way, I can think of 100 reasons that patients want their entire medical record, not the least of which is we're sort of beholden to our local healthcare provider and our local insurance carrier. And part of me wants to enable a new ecosystem where let's assume millions of people had access to their entire medical record. Well, HIPAA stands for portability. It doesn't stand, it's not a security framework. HITECH's a security framework. HIPAA was about portability. It was about moving your record when you left an employer. It's about portability. Why did we want portability? Well, we wanted the patient to be empowered. If you give 10 million people their medical record, their complete medical record, I guarantee you an ecosystem of providers, of clinicians, of technology companies, of remote patient monitoring will start to evolve around that. Now, some of those will be providers and some of them will be payers, but there will be a whole host of new options for you to care for your son and for everyone who's sort of challenged. But today we're sort of stuck with this system. It's like, well, this is the system and this is how it works and this is how it functions. And I think, the part of the reason I hate that money that flowed to all those companies, all the healthcare providers, was it essentially continues a model that does not work for a lot of people. It is sick care. It's kind of barbaric. Health system providers get paid when people are sick, and they don't get paid to keep me well. And it's a backwards model, and we need to open that up. And I'm not saying that healthcare providers don't play in that model. I'm saying we need to figure out a way to get them incentivized to play in that model instead of talking about it like, hey, we're going to do population health. Isn't this a great thing? Blah, blah, blah. No, let's actually change the economic model where there's a whole bunch of money in the wellness category instead of just the sick category, in which case healthcare providers are going, yeah, let's change our model. Let's figure out how to keep our communities healthy. That's my 2 cents. And I'm sorry, I probably talked more on this episode than I usually do. I apologize.
Well, I feel like we could have part 2 next week. There's just so much to dive in here too. That's the patient access to records is every patient has to have it. Absolutely. And because I don't have some life-threatening illness, I have to appreciate those patients who really desperately need their records like right now, immediately right now. I challenge you to go out to 5 of your CIO friends and ask them, can they send the USCDI today? And I will do the same I'll just randomly check in with like 5 members and then we'll reconnoiter next week. Okay. So we'll find out I'm pretty sure that the 5 I reach out to will all be able to do this. The thing that keeps me up at night now are things related. You talked about apps. We could have to do a whole other show about this. Have you seen the Finnish coverage about it's getting very personal? They're taking your information and they're holding you ransom, or otherwise they put all your personal information on the internet. And this just happened in Finland. And it's really, really scary. And it's just destroying patients and patient privacy, everything you hold dear. That's scary. That's, to me, is like one of the things that was on my mind this week, but I'll share that morsel with you shortly.
Well, it's interesting because that argument's used. I get that argument all the time. And people are like, if we give to the patient, this is what's going to happen. And I'm like, hey, look, we left it at the health system and it gets destroyed.
Not giving it to the patient. No. But if you're giving your information, whether it's through an app or to a provider, to anyone that you think it's going to be held securely, it should be held securely, right? It shouldn't end up on the internet, ransomed.
Mari, it is always fun to talk to you. And I know it's hard to believe, but we're talking about what's going on in the Beltway and whatnot. And this is a fun conversation. I look forward to, I think you're coming on again in a couple of weeks, and I look forward to seeing how the conversation progresses.
What a great discussion. If you know of someone that might benefit from our channel, from these kinds of discussions, please forward them a note. Perhaps your team, your staff. I know if I were a CIO today, I would have every one of my team members listening to this show. It's conference level value every week. They can subscribe on our website, thisweekhealth.com, or they can go wherever you listen to podcasts, Apple, Google, Overcast,
which is what I use, Spotify, Stitcher, you name it, we're out there. They can find us. Go ahead, subscribe today, send a note to someone, and have them subscribe as well. We want to thank our channel sponsors who are investing in our mission to develop the next generation of health IT leaders. Those are VMware, Hillrom, Starbridge Advisors, Aruba, and McAfee. Thanks for listening. That's all for now.